Hello, everyone, and welcome. Excited to be chatting with everyone today. Thank you so much for joining us. My name is Aiden Dowling, and my pronouns are he, him. I am the co-founder and chief advancement officer here at Point of Pride, and we're excited to have you with us for this special conversation, which is part of our Transgender Awareness Week programming. This week is all about uplifting trans voices, fostering understanding, and advocating for greater visibility and access to care for transgender and non-binary individuals. We're grateful to have everyone here as part of this important dialogue. Before we begin, I want to put a disclaimer out that this information provided is for educational and informational purposes only and is not intended as medical advice. Please always consult a qualified healthcare provider for personalized medical guidance. I'd also like to take a minute to introduce those who may not know what Point of Pride is and what we do. So we were founded in 2016, and we are a trans-led nonprofit organization dedicated to providing life-saving, gender-affirming support to transgender and non-binary individuals around the world. We offer direct services through programs such as our free chest binder and GAF program, our HRT Access Fund, our Electrolysis Support Fund, our Thrive Fund, and our currently open for applications annual surgery fund. Our mission is to eliminate financial and systemic barriers to care, ensuring that every trans person has access to services they need to live authentically and thrive. And I would like to happily introduce our guest for today's virtual workshop. Everyone say hi to Dr. Ronni, pronoun she, her, and any respectful pronoun. Hey, Dr. Ronni.
Hey, I'm so happy to see your face.
Yes. Dr. Ronni is an associate professor of family medicine and community health. She practices full spectrum womb to tomb, sperm to worm family medicine and has been providing healthcare for the two-spirit, queer, and trans community for over 15 years. In her clinical practice, she is committed to providing family medicine and
Obstetrics.
thank you.
Yeah.
Obstetrical care that is rooted in the foundation of promoting health, equity, anti-racism, and size acceptance. More recently, she has been co-producing and co-hosting a podcast called This Is Probably a Really Weird Question, which focuses on sex, gender, sexuality, and history. You can find it wherever you listen to your podcasts. Thank you, Dr. Ronni, for being here for this HRT Fireside Chat. For all wanting to ask questions, I just want to remind you that we will have time for questions at the end of this discussion. So there is a little Q&A chat box below. So if you could utilize that. And also shout out to Mel, our interpreter here, as well as Tyler, who is behind the scenes at Point of Pride, and will be dropping some information in the chat as needed. So hey, Dr. Ronni, how are you doing?
I'm good. I am going to be Dr. Mom for a second here and say goodbye to my child.
Oh, yes.
One
No
second.
worries. Do it. Because what I'm going to say is I want to talk to you about what HRT is. So this fireside chat is going to focus on hormone replacement therapy, also known as HRT. It's a crucial aspect of gender-affirming care for many transgender and non-binary individuals. HRT involves the use of hormones such as estrogen, testosterone, or puberty blockers to help align a person's physical characteristics with their gender identity. The journey of HRT can be deeply personal, offering relief from gender dysphoria and empowering individuals to feel more comfortable and confident in their bodies. Hi, Dr. Mom.
Hey, I'm back.
Welcome back.
Whew.
Again, thank you so much for joining us. I know that some people here may have seen you from our annual TikTok-a-thon, so it's great to have you back. How are you doing?
I'm hanging in there. It's been I love my job, and sometimes weeks like this are hard because people are really scared and stressed, and so I've been doing a lot of problem solving with folks this week.
Yeah, well, that feels real. I'm sure some people
Yeah.
here can relate to everything you're saying. So, I really wanted to jump off this fireside chat with kind of asking you, like, you've been doing medicine for so long, like what inspired you particularly to start working with transgender and non-binary patients? And specifically, I know you do womb to tomb. So what inspired you to work with our community as well as your specific approach to working with our community?
Yeah. So, I took kind of a slightly non-traditional path through medicine. So I actually started out in college as an English major, and, had one of those classic 20-year-old caffeine-induced frenzies in the middle of the night where I decided that English major wasn't going to help me change the world at all. So I ended up switching my major and starting to try a pre-med track. And I just got weeded out. Like the kids in that program were really intense and really competitive, and I felt like kind of my journey to medicine was going to take a different path because I just didn't feel like they were my people. So I managed to graduate with a few major changes, and then the person that I was dating at the time, we moved out to California together, and they were going through a gender transition. And this, I am old, so this was a long time ago. And even in the San Francisco Bay Area in the mid to late 90s, it was really hard for him to get the care that he needed. And so I kind of watched that process, watched him struggle and try to get through barriers and hoops. And I decided I worked in the healthcare system for maybe like 5 or 6 years, and then kind of maxed out with what I could do. I was working basically as a medical assistant, and felt like the next step for me would be management. And I did not want to do that. And I really wanted to do direct patient care. So I went to medical school in Philadelphia specifically because it was a city where I could get a lot of training and have a lot of community around me at the same time. Um, and then when it was time for residency, I wanted to go. I don't know if any of you know how residency works, but it's basically like a matchmaker, right? You make a list of all the places you would like to go and you rank it. And then all the programs rank you as an applicant. And then this magic computer in the sky matches you. And on one day you open your envelope and it tells you where you're going to go. You don't get a choice. So at the time I still have quite a bit of medical school debt. And I knew that the places that were doing this training were New York City and San Francisco and Chicago, all places that were really expensive. And also Madison, interestingly enough. So the clinic where I work now has a really, really long history of providing trans healthcare, mainly because of one person, right? One person can make an enormous difference. One person at our clinic sometime in the 80s looked around and said, this is a population that needs this service. There's nobody doing it. So he just started doing it. And so we became known within Madison as a really safe place to practice. And it became a way for me. It was kind of a door to all sorts of things, right? So I do a lot of just kind of sexual health and reproductive health care, and a lot of times gender care really meshes well with that. And I think the way that my practice has changed over time is that I have gotten more comfortable with being unsure, and I've gotten more comfortable with that are maybe off the beaten path. And so I've gotten a lot more comfortable really honing in and individualizing someone's care, because that's really the cornerstone of what we're doing, right? If you know like one trans person, and your goal as the person taking care of them is to listen and help them the best that you can to help them live their best life and feel like they're achieving their embodiment goals the best that they can.
Yeah, no, I love that. And I love hearing that story. And it sounds like there's a matchmaker that may or may not be a great match for some people out there in the medical world.
Right.
Happy you found where you're supposed to be. I
I
think that
found my people.
exactly.
Yeah.
I think that's really, important. So I'm, based on your podcast, I love you because I think that you have such a relatable approach. And again, anybody who has questions, please feel free to drop them in the Q&A. So I kind of want to start off first. A lot of people in this talk are gonna maybe they're interested in HRT, or maybe they've just begun, or maybe they're just not sure if it's correct for them or not. Do you have any advice for people who might be unsure?
That's such a great question. I think everybody deserves a good therapist, number one, right? Regardless of who you are, regardless of what your personal journey is, especially right now, we're living in a really stressful time. And I think having a good therapist is essential to help work through maybe some of that ambiguity.
Mm,
Um, I also think that it's okay to not be sure, right? Sometimes I think people get into this headspace because of the way that the healthcare system has operated in the past and treated trans and non-binary folks in the past. They feel like they have to come to the table with this story that fits in a really nice box of like, I've known since I was 3 that, always wanted to play with Barbies. I never wanted to play with G.I. Joe. And I got caught wearing my sister's dress and my parents got like that. You don't have to prove that you're trans enough for hormones. At least your doctor or your clinician should not be asking you to do that. So uncertainty is okay. Everything in life includes risk, including not doing anything, right? Inaction also involves inherent risk. And so doing your homework if you can, doing some research online. One of the best resources I think is there are two that I really love. One is UC San Francisco's Center for Transgender Excellence. They have a really robust and well-researched medical site that talks about risks and benefits of medications. It's a little bit geared towards clinicians. So if you want something that's geared a little bit more towards patients, Planned Parenthood of Michigan has a phenomenal website about
mm,
gender affirming care. And they have these little topics that you can just click on. And it goes through most of the questions that folks have before starting hormones. And also remembering that like nothing is etched in stone. If you start and it doesn't feel right, it's okay to stop.
mm. Yeah, I think that that's a great point. I think so many people think you've got to keep going, so to speak. How have you seen people use HRT to get those secondary characteristics that they're looking for?
Um, I've seen all sorts of things, some of which are, in the textbooks, as we like to say, and some of which are not. Sometimes people will use hormones indefinitely, right? And I have because I practice, womb to tomb, I have trans folks that are 10 and I have trans folks that are 80, right? So I see folks across the lifespan. And so some people use the medications for as long as they need them. And that could be until the end of their lives. And that could be for a short period of time. So sometimes people will use testosterone, for example, for a short period of time to achieve one or two things. That could be their voice dropping or achieving a certain pattern of hair on their face or body. And then they decide that they would like to stop, and that's fine. Sometimes people want to really go all the way to the other end of the gender spectrum. And so we try to like maximize their doses of medication within safe parameters, right? So we're monitoring labs and making sure that they're feeling okay. Um, and not everybody has that goal. Sometimes people want to use topical medication, so like creams or gels, either like on their chest to develop breast tissue or on their bottom parts to like help with bottom growth, or to help with discomfort. Like if people are having pain with erections, sometimes people have heard about, oh, I read about this thing on Reddit, right? I have learned a lot about Reddit. um, and I've got no skin in the game, right? Like I think when I was a younger doctor, I would have felt a little huffy about it and be like, what do you mean you're doing your research on Reddit? And now I just don't care, right? Like we've been crowdsourcing information in our communities for decades, and Reddit is a way that we do that. So we talk about it, right? We talk about whether or not that's a reliable source and whether or not the stuff that I know from other sources aligns with the things that they've heard. My goal is to keep people safe and alive so that they can enjoy their bodies, as they become more congruent. So my goal is to just like help people feel better in their bodies. And I'm always really honest with folks that I'm probably not going to be able to make someone look like Marilyn Monroe overnight, right? There's a certain amount of genetic building blocks that you're going to have, and that you're going to be able to achieve some things with medication, but it might not be everything.
I love that. I have a follow-up, but I want to check in on Mel, our interpreter. Technically, we were supposed to have two interpreters, so Mel could get a rest. So, Mel, if you want to drop the name of potentially the other interpreter you think is supposed to be here, and I can check the attendee list, I'd love to just pause for a second to do that. Fantastic. I'm searching here to see if we have this person here. Unfortunately, I do not see them here, Mel. So I do have transcription on as well. So take time that you need. I think most everybody would understand and respect that. Okay, awesome. So Dr. Ronni, that actually brings me to another thing is, can you explain how hormones like kind of work on the body? And maybe a better way of asking that is you were just saying you can't turn someone into something. It's
Mm-hmm.
all based on their genetics. So how do you explain that to people when they have specific expectations? Like they might say, well, I want a full beard, or they might say, I want to get rid of my beard, right?
Mm-hmm.
How do you manage some of those expectations? What are some of the things you advise for people to know?
So one thing that I talk about is, if you lined up 100 cis women in a row or 100 cis men in a row, none of them are going to look exactly the same, right? So some people are really curvy and have a lot of hair, and some people are not. Some people are really thin and willowy and don't have much hair. And sometimes this is even more complicated because sometimes people don't know their families of origin, right? If they were adopted or otherwise estranged from their family, maybe they don't know. So and I would say not everything depends on genetics, but that definitely plays a role. So for example, what we call male pattern baldness or androgenic hair loss, that gets passed
In this,
down. Yes, it's a sign of having a lot of testosterone receptors in your scalp.
the sign
um
of maturity
it's
and growth.
yes, exactly. Um, so if you happen to know your mom's dad, and if he was very, very bald and you start testosterone, you're probably going to lose your hair, right? And that's that's a genetic piece. Some of the other stuff that matters is what medications we're using and things like that. So, and I say that kind of almost verbatim in the consent that I'm doing with folks. I'm like, I don't know what's going to happen. And for some people that's really exciting. Sometimes it's like you're opening a present little by little and you're figuring out what you're going to get. And for some people it's incredibly anxiety provoking, especially if someone's goal is to pass, right? If somebody says, I want to be stealth and I want to pass, that in between time feels very, very stressful. So, I let folks know that what we know on average, right, is that most trans femme people can get about like a B or a C cup from medications alone. And if they want more breast size, then oftentimes that involves some sort of surgical intervention. Hair on the face, especially, takes a really long time. So people start getting hair like on their bellies and their backs and their butts and their chest, and their beard can look really sparse. And it can take like 3 to 5 years for people's facial hair to really kind of come in. And all that stuff that people used to tell you about, like, if you shave, it's just going to make your beard more coarse. Like none of that is true. What makes hair grow is time and the hair follicles, and those little hair follicles getting changed by testosterone. Um, and I am fortunate to be able to spend time with folks, and we check in and we adjust things if we're going along and that people aren't feeling like they're getting the results that they need. We adjust as best we can.
Right. And so would you say you adjust the opposite too? Like if people feel like it's moving too fast, are they able to slow down, for lack of better terms?
Absolutely. Yeah, absolutely. And sometimes, and we can do that for all sorts of reasons. Whether somebody is not safe where they're living, maybe they feel like things are moving too quickly and their voice is really dropping and they're getting clocked in public as a trans or non-binary person. Sometimes it's because they're just still figuring it out, and none of that makes them not trans enough. And I have folks that have stopped and started and stopped and started based on where they were in their lives and what they needed and their access to medications.
Mm,
The other thing that I think is really important is that if you're gonna start this journey of medications, be really knowledgeable as you can be about your family history, because things like heart disease and stroke and hormonally sensitive cancers like breast cancer and prostate cancer, all those things are really important for us to be able to create a regimen that's as safe as it can be. Um, and also being honest with whoever is prescribing you about your own medical history, that also helps us keep folks safe.
mm. Is there any, if you are somebody who's interested in starting HRT and you've kind of gone through that emotional part and you know that this is the right choice for you, are there any, like with surgery, there's certain surgeons who, you have to be a certain BMI or they won't work with you, or then there's some surgeons who specialize in that, in that. So is there any precautions that a trans or non-binary or gender diverse person might need to take if they want to make sure they're, you know, for lack of a better word, like ready
Yeah.
physically in their body for hormones?
Yeah. So, I approach a lot of these things from a harm reduction standpoint, right? I think probably one of the most important things that anyone can do for their health is quitting smoking. Smoking is really bad for your heart, bad for your lungs. It significantly increases your risk of having a blood clot somewhere where it's not supposed to be, like in your lung or your leg, or your brain, which is a stroke. So, quitting smoking is one of the most important things you can do for your health, hands down. Um, that being said, in my own practice, because I have a really harm reductive approach, I have very few hard stops, very few things that would cause me to say to a patient, "You are not a candidate for medications." Because I feel like I've been doing this long enough that we can find ways to help people get the hormones that they need and also again keep them as safe as we can. I think other things to know about it and talk to your clinical team about is the other medications that you're on, right? So there are some blood pressure medications that you cannot take with Spiro, and there are some anti-seizure medications that will become less effective if we start estrogen. And so really knowing your medications, and patients don't have to know that, right? Like I don't expect people to come to the table and say, well, I know that I'm on such and such anti-epileptic drug, and this is what I want to do, but I need to know what I'm working with. And then then I'll figure out what's safe. And also like health, being healthy is not a moral imperative. And that sounds kind of weird coming from a doctor, but you don't owe anybody you good health. And some people have a lot of barriers to health, right? If you are poor and uninsured and homeless, like you're just not going to be able to access the gym in the same way, right? Or fresh fruits and vegetables in the same way. Um, and that doesn't mean that those folks aren't entitled to gender care. So I would say you're worthwhile people and you should be here and you deserve to be healthy and well cared for. And so whatever you can do to care for your body will serve you in the long run. But really, I think, doing all this stuff that people always tell you to do, right? Like move your body in a way that's meaningful for you. You don't have to go run a triathlon, but if you can get out and walk around the block and get some fresh air, that counts if that gives you joy. Eating in a way that nourishes your body, if you can. Those
Mhm.
are, and, working with whoever is your primary care doctor on getting whatever medical issues are also in play under as best control as you can, right? Like if you have diabetes, working to make sure that your blood sugars are as under control as you're able, same with blood pressure or things like that. So taking care of yourself as a holistic person is really important.
Love that. What misconceptions about HRT do you find yourself addressing most often?
Hmm, that's such a great question. Um, I think a lot of misconceptions come um, from I hear a lot of concerns from parents specifically
Mm.
about young people. Um, and I don't want to go too far into the weeds with pediatric gender care because that's not a huge part of my practice, but I would say um, right now, especially misinformation and disinformation is at a frenzy. And so it can be really hard to know what's accurate and what's not. Um, so some misconceptions I hear are if I'm a trans femme person and I start estrogen, that I'll start having monthly cycles, like without bleeding. And I don't think I think there are ways to create a hormone regimen that is cyclical, but that's not automatically going to happen. Um, Sometimes I hear that what other misconceptions have I heard? We used to talk a lot about irreversible changes, so changes that will never be reversible. And I've started really shifting my language around that and calling it harder to reverse and easier to reverse, mainly
Mm.
because there are very few things that are completely irreversible. Um, so, for example, we used to say, if you start testosterone, once that voice box enlarges and your voice drops, that's irreversible. And while it's true that your voice doesn't go back if you stop testosterone, there are things that we can do, as you know, after your voice training fireside, that there are things that we can do both through speech therapy to help pitch the voice up. There are also some surgeries that you can do to actually shorten the vocal folds that also pitches the voice up. All those things require time and money, and some of them are very invasive, but having your voice deepen isn't truly irreversible. The thing that I consider almost completely irreversible is bottom growth. So if you start testosterone and you get a lot of bottom growth or clitoral growth, that's that doesn't go back if you stop testosterone. And also, I don't know of really any surgeons in this country that are doing things to make clitorises smaller, unless you're unless you're an intersex kid, and then then the bar is open for surgery. But
Of
um,
course.
yeah, so I think in general, I think that whole idea of completely irreversible changes is a little bit of a misconception.
Yeah, that makes sense. So one thing that there's a lot of in-person doctors like yourself, which is amazing, but there's also a lot of people who don't have access to in-person doctors, so they've been utilizing telehealth in replace of that.
Hmm.
Is there anything, and this is kind of related, I guess, to telehealth, but also to in-person, is there anything that we, should be asking our doctors? And I think I just mentioned the telehealth because I do think that people tend to not engage as much because it is through a computer
Hmm.
or a phone or something. So is there something that we should be asking our doctors to make sure that they're a good fit?
Yeah. Sometimes people don't even have that privilege of trying to find someone who's a good fit and they just have to take who's available to them.
Yeah,
But, you
very good.
know, but I would say even before you get into the either virtual exam space or the real, or the in real person, in real life exam space, is word of mouth. If you know folks who have had good experiences with clinicians, then I would feel more comfortable seeing them. And obviously not every person has a good experience with every single doctor, right? But if you know that that person is trans affirming, that's a huge step in the right direction. I think asking what haven't I asked you that you think is important for me to know can be really powerful. Um, when I meet a new primary care patient, if I have time, I really like asking people how they want their relationship with their doctor to go. And people usually have never been asked that before. And so it takes people a little bit by surprise. But maybe asking yourself that question before getting to the appointment, like what's do I need and want from my relationship with my doctor? And if it's, for example, I need to know that if I send you a portal message that you'll respond within 24 hours, then ask for that. And if they can't do that, then at least you know that you either need to go somewhere else or that expectation won't be met. So kind of having an idea of what your needs are going into it can be really helpful. I think it's fair also to ask, do you have experience doing this? And if not, how are you gonna increase your knowledge? Because you as a patient should not have to educate them. There are a few online services I think are amazing, right? Like the Queer Doc group is fantastic. Plume, I think, is also quite good. And if you, even if it's online, sometimes you can build a relationship with folks that feels more authentic, even though it's 2D. I don't know if that answered. Did I answer your question? I kind of went
I think
off on
so.
a tangent.
No, I mean, I think you did. I think you did. So everybody who's here, we're gonna get to questions in just a few minutes. So if you have any questions, you can drop them in that Q&A. But I wanted to ask you, Dr. Ronni, what are you? So can be a tough time in this moment. A lot of uncertainties some people may be feeling as we move into 2025.
Mhm.
But if we stay on a positive note, what are you actually like the most excited about as, HRT has become more accessible, people know more about it. I'm sure your practice has changed drastically from
Mhm.
10 years ago. So what are you actually excited about in the world of, HRT?
That's such a great question. So I just went to the WPATH conference a couple months ago, which is the World Professional Association of Transgender Health, and I was feeling a little jaded about it. Like maybe I wasn't going to learn a lot, but I learned a ton, and I'm really excited that there's actual research being done. Right, for a long time we were doing this work without a net, and we were doing this work without any sort of evidence or data. And we were just going based on kind of consensus opinion. And now we're getting more and more actual data and research about, for example, can we get the same blood levels of estrogen using injections and using patches? And now actually somebody is studying that. And so we can start advising folks based on the data that we have. There's a lot of really cool data coming out of Scandinavia around being neurodivergent and trans. And that I think that's a new area of research that is going to explode over the next 5 to 10 years. But I also kind of nerd out about identities. And so maybe that I'm particularly excited about that. um, and, I'm excited for the young folks coming up. Like when I was applying for residency, like I said, there were only a few places in the country where you could learn it. And now medical students that are coming to interview for residency positions, it's almost like a litmus test for them, right? Like if they can't learn how to do gender affirming care, that could be a game changer for them. That could be a hard stop and say, I'm not going to apply to your program because I need to learn how to do this. So I'm really excited about the young folks that are coming up and demanding this training and demanding this knowledge.
That's cool. That's exciting to hear also as somebody who just celebrated their 15 years on T.
Woo.
And, finding a doctor was very difficult. And
Mm-hmm.
so much appreciate all of that. And so before we begin questions, if you do feel inspired by today's conversation, we do encourage you to make a donation to Point of Pride. Your support allows us to continue providing free gender affirming services like HRT access to trans individuals in need. Donations can be made at the link Tyler just dropped. Thank you. Or you can text the word trans futures to, this, Dr. Ronni, 44321. Every contribution makes a difference. So now on to questions. So I have my questions pulled up over here. So if you see me looking over here, I'm just looking at questions. So as a reminder, you can drop questions into the chat in the Q&A. You can also hit the thumbs up button if you want to answer, kind of vote up a question. So I'm going to go with this very first question we have for you. So Dr. Ronni, I am currently receiving hormone treatment from my PCP that was carried over from Planned Parenthood. I think the dose may be too low for my size. How do I determine what is the correct dosage? I'm on
Spironolactone. Mm-hmm.
Yes, and estradiol.
Yeah.
Dial?
Estradiol. Mm-hmm.
Estradiol. Okay.
Yes. So I'm going to just like remind us all of that disclaimer at the beginning. I am a doctor. I am not your doctor. But that being said, let's first give a shout out to Planned Parenthood, because Planned Parenthood all over the country is providing gender affirming care to folks who are uninsured and who need it. So thank you, Planned Parenthood. So the dose based on body size, I think we use body size a lot to talk about birth control, particularly and efficacy in preventing pregnancy. So there are some birth controls that become less effective with a bigger body size. One of the ways that I determine whether or not a dose is working for a patient is talking to the patient first, right? Like hearing how it's going, hearing like what changes are they noticing that are welcome? Are there any changes that are happening that are unwelcome? Like, is spironolactone completely destroying your erectile function? And that's actually something that you would like to maintain. And I do monitoring labs with some regularity. So when if we consider day 0, the day that we start medication, I'm checking labs every 3 months for that first year. It's pretty busy. So I would say I am not married to the numbers, and I encourage people also not to get married to whatever the numbers are for their blood draw, but it helps guide us, right? It helps tell us if we're trying to suppress testosterone and increase estrogen, what is that balance? And could we work more on suppressing testosterone so that you could feel like your estrogen was having more of an effect? And so there are also sometimes changing the way that you get estrogen into your body can make a huge difference. Like if you've been on pills for a long time and you feel like you've kind of plateaued, sometimes switching to either patches or injections can actually get you back into that pattern of changing. So I would say determining the correct dose is based on you and how you're feeling and whether or not your goals are being achieved, and then also blood levels.
When you say goals being achieved, I think like we're also caveating that with like you want like I always go back to a beard as a trans man myself. Like if you want a beard, you do need some time, right? So your goals might take time to get to your goals, but as long as you're on the trajectory, right?
Right. Exactly.
Awesome.
Yeah. And sometimes people have goals that are really vague, right? Sometimes people have goals that are like, I just want to feel better in my body. And maybe they will be on a dose of hormones that make their brain feel really good, right? And make it finally they feel like their brain is functioning right. They feel better in their bodies and in their minds. And maybe nobody on the street would know that they're taking any medication, or maybe even somebody that they love wouldn't know necessarily, but they feel really affirmed and better. And sometimes people have really specific goals, like you're talking about, like, I want to be able to have like a, an evil villain mustache that I can twirl.
Yeah.
But so sometimes we have to readjust our expectations, but we try to move as much as we can towards those embodiment goals.
Thank you. So our next question, this kind of goes into what you were just saying about if you were taking, a pill, maybe you're going to start a patch of some kind. Anonymous attendee asks, what are the benefits and drawbacks of gel versus shot for testosterone? And I'm actually curious because like I've always heard that, oh, if you take the gel, it's slower. If you do intramuscular, it's faster. If you do sub-Q, it's in the middle. Like, and I'm always just like, I don't know I don't know. Do you know?
So I would say what we do know about injections alone, right? If you're comparing intramuscular and subcutaneous injections, they are equal. So you get the same serum levels of testosterone. You have the same outcomes. So I'm almost exclusively recommending subcutaneous, mainly because it's way less stressful for people. And we could use a smaller needle. And that, I think sometimes that motion of having to like get a needle into your muscle can be really stressful for people. So subcutaneous tends to be a little bit of a smaller hurdle to get over, and sometimes people are like, oh, I had to do insulin injections for my cat. Is it basically the same? And it's exactly the same, right? So sometimes that feels like something they can really get their arms around. And I would say what I hear from folks anecdotally is that they feel like shots work faster. Faster isn't always necessarily better. And I can get people wherever they want to be with whatever, right? If I feel really confident that we would be able to find a regimen with topical gels that achieve someone's embodiment goals, it might take a little bit longer, but I'll get them there. I think the big things to know about gel is that you could unintentionally share it with somebody. So you have to be really mindful about skin to skin contact. And you need to give yourself enough time to let that gel soak in. I usually tell people about 3 hours. So if you're going to be having skin to skin contact with anybody, sexual partners, kids, pets, whatever, you need to either have it covered with an article of clothing or hop in the shower and rinse off. Some folks are, I think there was one slightly underpowered study that looked at people who were doing laundry of someone who was using topical testosterone and that they got a little bit of exposure that way by just like picking up the laundry. So if you want to be extra cautious and kind, I would say maybe do your own laundry. And then the other thing to know about gel is that there is gel that you can get at like Walgreens, for example, like a standard pharmaceutical gel. And then there's also compounding pharmacies. And a compounding pharmacy is basically like potions class, right? They'll make you whatever you want. And so if somebody is non-binary and they're like, I don't want to masculinize a ton, or it's really important to me that I go really slow, we can actually use a compounding pharmacy to make something that's a little bit less potent than what you can get at Walgreens. So we have a lot of like that dial to adjust the dose is really finely tuned if we're using topical or compounded products, because I get to decide what the concentration is as opposed to the pharmaceutical company who decides what the concentration is. And similarly with injections, we only have 1 or 2 concentrations of that oil. And at some point, there's just like a minimum that is practical to draw up, right? You can't draw up a drop of testosterone. It's just not practical. And so there's kind of a bottom limit of what the dose can be with injectables. And we can go below that minimum if we're using gel.
Awesome. So we're going to answer just a few more here as we're coming to time. Um, are there any hormones that work better than spy? Can you help
Mhm.
me?
Yes, you could even just call it Spyro.
Okay,
Yeah,
Spyro, because that
Spyro and
reminds me of the
estradiol.
game from
Hmm.
PlayStation. Spyro and estradiol.
Hmm. So I would say yes and no. Everybody's body is really different. Spironolactone is a very effective T blocker. It works very quickly. It works very well. The way I think about hormones as they're like keys looking for a lock, right? And so your hormone receptor is like the lock, and the hormone is the key, and it's trying to get into the lock to do its job. And spironolactone blocks that lock, so the key can't get in. So, but that lock is all over your body. It's not just in one place. And so you also have hormone receptors in your breast tissue. And so there's some people are a little bit concerned that if you start with spironolactone, that you could be blocking some of those estrogen receptors in the breast tissue, and it may inhibit breast growth. I don't know if that's actually true. I think physiologically it makes a lot of sense to me. But so if someone has an embodiment goal of I really want to maximize my breast growth, maybe don't start with spironolactone. Maybe just start with estrogen, for example. And then there's progesterone, which is another sex steroid. And I think the data is pretty mixed on progesterone about whether or not it's necessary. I do a lot of shared decision making with folks. And if it's something that is important to them, I'm happy to prescribe it. I usually just tell folks the main risk is that it can make you very sleepy. And so take it at night. And I have a couple times seen it make depression way, way worse. And so we just have an agreement that if your depression is getting really bad, that we stop it, because the most beautiful breasts in the world are not worth your life, right? And so um, I'd say there are lots of combinations of medications besides spironolactone and estradiol that you could potentially look at.
Ooh.
Yeah.
Great. So, last question here. Sorry to everyone. It would be impossible to get to everyone's questions, but I thank you all for asking them. I know you talked a little bit about this, but it was brought up again, so I think that maybe we could talk a little even more. What's the best way to address the transition goals question when starting HRT, and maybe
Mm-hmm.
you don't exactly know yet beyond not this?
Yeah. What a great way to phrase that. And I would say it's an iterative process, right? So you might start on something because you're like, I don't know what I want. It's just certainly not this. And then as you start, things clarify, right? Because I've had a lot of people say, I don't know, maybe maybe it's not right for me. And we start something and they're like, oh yeah, this is it. And I want to keep going. I want more of this. And sometimes that doesn't happen, and that's okay too. And we have other work to do. There's this really wonderful, I'm sorry, I'm looking away from you because there's I can't remember this person's name. There's somebody who does these great videos about gender therapy. Um, oh, I'm not gonna be able to find them now.
Well, what you can do is you can email me.
Oh, I'll do that.
We're gonna have a replay of this, and I'll put the all of your links as well in there.
I love it.
Yeah, so
And if I type answers to these questions, will those be able to go to attendees or no?
I don't know. You can experiment.
Okay.
Okay,
Maybe I'll just copy and paste them all and send them to you in a document. I don't know.
Yeah, I love that. I
Okay.
love that. Well, all in all, thank you, Dr. Ronni, for this awesome event.
Thanks for
Thank you
having
to
me.
everyone who asked questions, and also thank you all for your attendance today. If you'd like to stay connected, I will drop Dr. Ronnie's information in the chat. Or actually, I'm lying. Tyler will drop that in the chat. But as I just mentioned, we'll also have this event on replay on our blog at the end of Trans Awareness Week, which will also include Dr. Ronnie's information and all the resources mentioned here today. I do encourage you all to stay connected with Point of Pride by following us on social media at Point of Pride ORG. and subscribe to our newsletter to get information about all of our programs and when they're open for applications. Remember, if you'd like to support our work, donations can be made at the link in the chat or by texting TransFutures to 44321. Before you all leave, I want to remind you of another program continuing actually in just a half of an hour. We will be having a breast augmentation and orchiectomy. Am I pronouncing that correct, Dr. Ronni?
It's actually orchiectomy. Yeah.
Orchiectomy.
It's
Oh,
like
thank
an
goodness.
orchid. Yeah.
Okay, because I was about to go into that with the wrong words off the get. So thank you. For our orchiectomy, that'll be starting in just a half hour. You can still sign up. Just go to our blog or our Instagram. And if you want to see all of our programming for the week, again, you can check out our socials and our blog at pointofpride.org. Mel, thank you so much for being here, putting in that extra work. Tyler, thank you as well. And as always, Dr. Ronni, it's a pleasure to see you. I hope everyone has a fantastic Transgender Awareness Week. Bye.
Thanks so much.